we need to set standards and push the idea that you have standards. Then we put it in. But without standards, to me, I don't think it will help you much. I understand what you're saying, and I applaud that.
Yes. Maybe we could start to, maybe we can stick to a couple of the bad things we're doing it, they can.
I don't know.
Yes.
I understand what you're
Something
saying.
has to be there somewhere because so that's a debate that will happen.
Well, I'll tell you,
The responsibility of the investigators to this whole process is exactly because every investigator. What it really means, so can I intervene? Now, you say, I mean, we did a study. Firstly was done at Ayurvedic pharmacy, Coimbatore. We don't know the name, we can't report the name, but I'm saying. So it was done here for 7 days for a particular disease, and the symptoms did not improve. The same procedure, we say, was done in a outside some center somewhere deep in Tamil Nadu, and there also the same thing is reported. Independently, when you see which one do you tend to believe, which one do you think is more likely to be correct?
but we've been there. For example, when I see an article, I look at the authors, and under the authors, it says where they're from. So if this says the institution is Coimbatore, and it's the major one in New Delhi, and then I say, all right, I believe it.
Yeah, I think we were trying to get to a little bit more detail that the institute we believe in. But the question of, because it's so, we keep on saying that treatment is so complicated. Alright, why is it complicated? Is it just the logistics or is it the expertise of the person also? What I've heard that expertise of the person is extremely critical. Not just in treatment, diagnosis, all those kind of things.
Okay, so let me tell you what happened in the West. Okay? It was truly garbage in, garbage out for 100 years. And then in 1863, there was a report. I think it was called, I forget, I was calling it the Baxter Report, in which they said, we have to standardize things. And from that, people began to do that. And I think when you do that, then it's time. Then there's a difference between Kodankyu and the university. Until then, I think
No, you're absolutely right. No standards existing to expect something to be written about that is a little bit
But
of a problem.
obviously, at the end of the day, that's my.
But we'll see. We'll have to work it out.
Then another issue that I really wanted to talk about was apparently you all feel that you need your own endpoints, Ayurvedic endpoints. And that's great. But as they say in Spanish, cuidado. Be very careful. Because to use an endpoint without validating it really messes it up. And I'll tell you how long it takes to validate an endpoint. It takes 2 years of hard work. And you know,
Including scales, even
phase, content, construct, criterion, reliability, discrimination, responsiveness, feasibility. You don't do that overnight. So if you want to do it, but don't just publish it.
First, what about just
you've been trying to say something.
Yeah.
Just I want to one suggestion here. A lot of exercise has been done that I witnessed during this developing this philosophy. This is the reporting system. But think about the protocol. If the protocol is not according to this, I think that the person cannot report. So I think with a little bit exercise, this can be converted some guidelines for protocol design.
That's the end point. That's the end result.
That is the end means
What where we want to go.
yes.
Well, we all know that the point you made is excellent. You want transparency. And with transparency, you need clarity. And so you have to have clear objectives and specific aims and methods, and you need a clear protocol, outline, the analysis, and all the consort guidelines do is take that protocol and codify how you write it out. So the two are intimately associated, and I think that's right.
So the question then is that I would be very happy reading a paper that says that all my judgment of whether my treatment works or not for say diabetes is just based on HbA1c. And the way the person was diagnosed, because Ayurveda, which is the 17 points, do not play a role in the final conclusion whether the patient is benefiting or not. As long as the person writes that, I'm okay. The question is that this disconnect. What was the thought process in designing the trial and what is reported is what my problem is. As long as people are transparently saying that only Western biomedicine endpoint was used, fine.
Well, but that's what you're all been trying to do.
And that is not what all the time, because the problem is a negative study. If somebody stopped using the treatment that you tried in diabetes, did not work, you stop that in practice.
No, that must be a problem with the design of the study. The issue is
That's exactly what I'm trying to get at, because there's always an excuse.
the inclusion and exclusion criteria. We have to be very sure. Are we targeting only diabetes?
No, but this is exactly my point. This is
Or
what I
we are targeting Prameha or anything else?
It's one person at a time, okay?
So this is exactly the point that we, at the end of the study, we don't go back and say, due to the design of the study, the treatment failed, because it has failed all of us. Now we don't know, we're back to square one, we have conducted a study. So the question is that consciously I decided that diagnosis is Ayurvedic, treatment is holistic, endpoint is HbA1c.
So, let me make
That's what should be written
I think
down.
our study was good that we diagnosis is allopathic, outcome is allopathic. Your thought process behind that treatment may be Ayurvedic. That you can through things you can just.
And that study is the one which got the Jadam score of
Yes.
5.
Let me make a point, okay? The point is the word research. And whatever you do with one study does not prove the point. It's research. You gotta do it a couple of times. And only with transparency will you be able to make a judgment whether that's good enough or not. So the critical point is being transparent and clear. And what you all are trying to do is systematize that. And however you decide to do that, it makes all the sense in the world. I think using the consort as your basis makes sense. I think continuing to do that with tweaks to make it clear is what you need to do.
Design in the story, according to the important principle criteria, when you take up either subjective or objective symptoms or signs, the measurement of each one, we have to follow the international standard only when we want to make the scientific field to understand or to publish. So they, how do you think of all the
So I think those 2 points are intermingled in everything. It's just that we are sure only a kind of time.
Yeah, I think that's what that is.
So now here's the question.
You speak up a lot. Let others talk.
Yeah, right.
So there's just one thing, because I think what of course just mentioned now has a serious implication for Consortia exercise itself. Like practically what is going to work is that we stick to the consorts and that the tweaks, I mean that's what I wanted to ask, is that how do we get that done? Because we have to do something that will make a change in the way Ayurvedic papers are. Like practically we have this problem. If we write up some papers and send it to big journals, we do want some accommodation at that level also. Because if it contains things that we want to, include, the present consort guidelines may not be accommodated. And that's where we need to really make some change. How can this be done?
Let me make a suggestion here that actually works. Okay? Which is you have an introductory letter which says we're sending this to you, we're trying to follow guidelines. There are a few areas where we think we have to change the way we present the Veda. We hope that you find that acceptable. So now the editor is ready to understand that it's not strictly following the guidelines. Rather than forcing it or changing it and not letting it know, these editors basically, not all of them, but basically are looking for good material. And they're going to be much more flexible if they understand where you're coming from. So rather than saying, well, can't do it, going to do it differently, just say we tried, we have to change it a little bit. I hope that you understand. And that's all you're going to need to do. So you don't have to, you don't have to meet all 17 points. No one ever does. Okay? But you can say we follow the Consortia guidelines generally. Period. So that's, you don't have to re-educate everybody. Does that happen or not?
Yeah, but there are just other things that you mentioned that an Ayurvedic study should have Ayurveda in the title.
These are specific.
Yeah, but how does that get kind of,
The word Ayurveda, I think that's what he meant.
Yes. No, how does that get enforced? Like, how does that get enforced? Because we find that there are also studies on Ayurveda which might still.
I think upfront we said it's not going to be prescriptive.
No, but what
We can't know that.
No.
I mean, it's only suggesting we should spread the message around.
If you go
Just
off
talk
the
first concept.
I think that those of you who are here are going to be the leaders in the good clinical trials. You have people who will teach you. You say it. After a while, it'll be easy. So when you publish it for the Ayurvedic community, and then you follow it, it'll happen. It's really, you all are basically the leaders of the future clinical trials. So if you buy this, it'll happen.
So I think Consortia would have that relevance more to the Ayurvedic community.
But it's to lead it outward.
Yes.
So, if you know to use the word Ayurveda, and that's done when you send it somewhere else, it will be somewhere else.
If there are ethnobotanical trials or some kind of okay, but ethnobotanical application, but maybe the source is Ayurveda, but then they say it's ethnobotanical or some kind of single herb trial. Then how?
non-clinical cases, in non-clinical studies. In
No, in chemical also there are ethnobotanical designs. Also.
No, what doctor was suggesting was that not everybody will stop doing this because of time. But as we start doing it, more and more people will fall in line. That's what this time.
And I think you're going to find that there are going to be people who use the word Ayurveda who don't do Ayurveda.
Yeah.
But you can't police the world. You can only do what you can do. And I think if you keep the standards high and you tell your fellows how to keep the standards high, they will go on.
To answer his question, the question that you asked, I think it's a question you asked. He's saying that inclusion criteria, if it uses Western biomedicine, should I write it like that? With clear and the Ayurveda doesn't say that. The question is how should it be done? Is the question. And the way we have suggested that thing, the sense that came out is that you have to use Ayurveda principles. So that is something that
what she said.
yeah. So I just want to make clear that that was not a suggestion. Whatever you do, you have to write it.
Yeah, okay, yeah. I think that was the confusion I was
It's
having.
perfectly alright for having a Western endpoint, as long as, like you were saying, the principle which is gone into the treatment or the diagnosis may be Ayurveda, and you're using a Western endpoint, that's perfectly fine. But that needs to be stated, not, without just taking it out there and putting it there, I won't do this.
Yeah, if you study HbA1c, you don't call it as a study of Prameha, you call it a study on glycosylated effect of this on this.
Whatever you do, that should be good.
So I think that is the point of transparency. They are doing an ethnobotanical. It's just that the reader should be able to make a judgment. You must have all the details there so that somebody can judge whether it is really an Ayurvedic trial or not. I I mean, we cannot force them to, do something else. I mean, I think that's the point. I mean,
I really do believe what you're doing is in part to get these articles to the whole world, but it's also in part to educate your own community. And so these guidelines are very useful internally, and so I really think you're doing the right thing to get this out.
Just as a wrap-up thing, I think the discussion is absolutely wonderful because some of these things that was just pointed out will downplay, some of these things will take down because we expect standards, suddenly they'll not go on. Some of the ideas of using appendices, especially in electronic journals, I think gives us a way out where if it has to match 2,000 words, but you have more to tell. I think we can take the guidelines, use appendices, we can give some suggestions.
And I honestly would suggest that you talk about using beta testing to prove the efficacy of your placebos. That's what I call it. It's before the trial.
That will put it in that if you're using blinding. Holistic treatment of blinding becomes a little difficult, so if it's massage and panchakarma, that becomes very, very difficult. Then I think independent evaluators need to be there.
I think what he said in the morning makes all that sense. We will only try to differentiate those things which can be differentiated. Start with that, the rest will follow. We will have to develop more complicated.
Yeah, so there we will give some suggestions that full blindings aren't happening. The evaluators will get some endpoints which are based on lab parameters. Can they be used and things like that? So to replace, but if it's a treatment which is simple, then I think it's fine.
Can you just explain what you meant? What exactly do we test with those 4 cases? 4 or 5, the meter testing?
So the question just came up about what in the world I was talking about when I was saying beta testing. What I think needs to be done is you need to be able to feel comfortable that the placebos that you prepare are successful placebos. So you give the patient the preparation with the drug in it, and give the placebo preparation, and say, so I need one of 3 answers. This is the real stuff, this is the real stuff, or I can't tell. And the answer you want is I can't tell. Right? Or you want the other answer, which is they got it wrong. Right? So if you do that with each of your preparation in 4 or 5 patients, you're done.
Right. So organoleptically, or not after the long-term effect is seen. Immediately the reaction should be, I'm not able to do it. Yes.
Before the crash.
Immediately organoleptic. Right.
Sir, actually the study says like RCT and is shaking. So we are still following RCTs. Is it the group, this
I'm sorry, I don't get you.
is it only